it's my pleasure to introduce Dr. Peter Black. He's a urologic oncologist at the Vancouver General Hospital. He's a research scientist at the Vancouver Prostate Centre, and he's an assistant professor in the Department of Urological Sciences at UBC. He completed his urologic training at the University of Washington in Seattle, and then did a fellowship in urologic oncology at the MD Anderson Cancer Center in Houston, Texas. He treats all urologic cancers, including prostate, bladder, kidney, and testes. His research interests lie in discovering new treatments for bladder and kidney cancer. And Dr. Black has been a strong supporter of Kidney Cancer Canada from the beginning and has served on our medical advisory board since its inception 4 years ago. So please join me in welcoming Dr. Peter Black. Thanks so much, Peter.
So, thank you very much, Joan, for that introduction. Where do I have control? There we are. So I've been given the task to talk to you a little bit about treatment for kidney cancer, and there is a time at the end for questions and answers, but if you really don't understand something I'm saying, do shout at me and we can potentially interrupt. So I am a surgeon, so you'll find that I'm going to talk more about surgery than medical management of kidney cancer, but we will get to that as well. So this shows you a little bit of the timeline of kidney cancer and how things have changed over time. In the 50s and 60s, patients used to present with what we called the classic triad, which was an enlarged palpable mass, blood in their urine, and pain in their flank. We then developed new imaging, ultrasound, CT, and MRI, and had a shift where all of a sudden patients were turning up with little tiny masses in their kidney that otherwise might not have been noticed. And that has, sorry, didn't know there's a camera there. That has changed also how we treat. So we used to, back in 1968, the radical removal of the kidney nephrectomy was a brand new operation. Yet as we had more and more smaller masses being diagnosed, we moved to partial nephrectomy, which was described first in 77 and really became an established procedure in the 90s. We're now at the point where some tumors are small enough that we're doing active surveillance, so we're not treating them at all, we're just watching them and seeing how they change over time, or we're employing new technologies here, such as freezing and heating the tumors. And so I'm going to go over some of these things as they've changed over time. And I will start with the surgical management. So surgery plays a big role in kidney cancer because it can be used in many of the different settings, whether it's the earliest tumors or the advanced tumors, even recurrent tumors and metastases. Now, most cancers, we will not be doing surgery if it's spread to somewhere or if it's come back. But for kidney cancer, there is room for all of this. So the classic operation, the radical nephrectomy, is removal of the entire kidney with the mass inside. We basically cut off the blood supply, cut off the ureter going down to the bladder, and we take out the kidney in the envelope of fat that surrounds it, including the adrenal gland. This is sort of the classic operation that we actually don't do as often anymore because of all the other options that we have. We do it for more advanced disease. A cytoreductive nephrectomy is what we do when a patient actually has metastases. So the tumor is already spread, but we know that those patients will do better even if we remove the kidney, provided that we're able to get them on to chemotherapy as well afterwards. It's not going to cure the patient, but it will improve the longevity and the quality of life. We used to do it, a nephrectomy strictly open. We now do a lot of them laparoscopically, although the bigger ones we still do open. You can see here a patient lies on his side and gets an incision up top here just off the ribs. I like how this one's marked as 8 to 10 centimeters, if this one here is probably about 25 centimeters. But this is the surgeon's wishful thinking here. And this is what it looks like laparoscopically, where we have one hole around the belly button that's a little bit bigger where the camera goes in and where we can take the specimen out later, and then just small holes where we put in other instruments and we can dissect the kidney out completely without the big incision. And you can imagine that a big incision on your side between your ribs is fairly painful and takes quite a while to recover from. So laparoscopy for removal of the kidney was a big improvement. I mentioned that we can't always do laparoscopy. One of the limitations up until the last few years is just that not all surgeons are trained to do laparoscopy, but that should be something that is less important now. But some patients are just not made for laparoscopy. If they have bad lung disease, then we can't fill their abdomen up with carbon dioxide at a high pressure because they won't be able to breathe appropriately. And if they've had a bunch of prior surgeries, or really the most common reason is just that the tumor itself is too big or inappropriate for laparoscopy. One of the newest things out there is single port laparoscopy, which you're not going to get in BC, and I don't think anywhere in Canada right now, because it's really just under development, and there are a few people in Europe and the US who've done a handful of cases, but you can see you have this special port where now all of your instruments go through one port, and that port is just below the belly button. And it requires some special technology because your instruments cross and bend and do all sorts of funny things that are in no way intuitive, even for the best video gamer. The other new idea out there that's being explored is called NOTES, or natural orifice surgery. And this may seem a little creepy to you, but this, for example, is going through the vagina to remove the kidney. So the instruments are going through the fornix, or the apex of the vagina, just behind. You can see this is a uterus, so it goes in behind there. This one, this of course only works in women. This one here, there's a scope going up through the rectum into the abdominal cavity, as well as a scope coming down through the stomach. This has been done for removal of the gallbladder, which is a more simple operation. It's not quite there yet for removing the kidney, but people are trying these technologies, and it'll be interesting to see where it takes us. Now, one big concern with removing the whole kidney, which has been the cause of some of the shift to the newer technologies, is that people really, they need two kidneys, or to some degree need two kidneys. They do better with two kidneys. Most patients will be fine if you remove one kidney. They won't notice the difference. But the kidney function, if you measure it, is decreased. And we've figured out, especially in the last 10 years, that even this low level of kidney failure the patient doesn't notice puts the patient at a higher risk for heart disease and things like heart attacks. So we've really recognized that it's vital to preserve kidney function as much as possible while treating the cancer. Just here, while a patient will notice no immediate negative consequences of losing 50% renal function, it will have a negative effect on their long-term cardiovascular health. So that's very important, especially in younger patients. So this is part of the reason why there's been a big push for partial nephrectomies. At first, especially in the 80s, this was considered a radical idea and way out there, and something you would be heckled off the stage for if you presented at a scientific meeting. And now it's turned quite the opposite, that if urologists aren't doing enough partial nephrectomies, people are sort of looking over their shoulder and wondering why not. So this can be done either through an open incision, it can be done laparoscopically or robotically. Generally, if it's a little bit trickier, it's done open, and otherwise it can be done laparoscopically. And you can see here how the tumor is right here in the middle, and we basically cut around the edge and just pull the tumor out and then sew over the defect. The difference between this picture and real life is that there's a lot of blood in the kidney. Robotic is, of course, a sort of a sexy new technology that patients and surgeons alike like. This is where the surgeon gets to sit off in the corner here on a console. He can have his cup of coffee next to him if he wants. And the robotic arms hook up to basically laparoscopic arms that go in through ports. So there are multiple small holes. And the special thing about the robot is that the instruments are wristed. So you can see here, the same way you can move your wrist, you can also move the instrument. So it gives you great dexterity. And that's important with cutting out the tumor and then sewing over the defect. It's not used so much for a radical nephrectomy because it's just not necessary. You don't need that dexterity for the radical nephrectomy. And then, of course, the ultimate in technology is probably the single port robotic surgery, where you have everything going through that one port at the belly button. Again, this is experimental, not in widespread use. So partial nephrectomy is done in some cases because it absolutely has to. So I did surgery today on a gentleman who has about 10 tumors on each kidney, and if you take out both, then of course he's on dialysis, and it's a young patient with a congenital condition that gives him kidney tumors. So it's very important in those cases to spare kidney tissue as much as possible. So that would be the one here, bilateral tumors. There's also patients who only have one kidney. They've lost a kidney maybe from infection before, or maybe they had a tumor before, and now they have a new one. And then of course, if their kidney function is bad enough, even if they have two, but you take out one of them, they're going to go on dialysis, and that's considered something where you'd really go to great lengths to try and do a partial nephrectomy. Then there are other reasons as well. Basically, if we think that it's likely that patients are going to have problems with renal function later, then we really should be pushing it. And it's come to the point now that it's really done in almost all kidney tumors that are small enough and feasible to removal, even if the other kidney is normal. It used to be called an elective partial nephrectomy. The unfortunate thing is that there's a lot of good evidence that we should be doing more partial nephrectomies, but we're not necessarily as a community of urologists. And I think that the trends show that we're doing more and more, but still most patients with a small renal mass will have a radical nephrectomy, whether in Canada, the US, UK, or elsewhere in Europe. And this is something that we need to improve upon, and it's one thing I think is important for patients to some degree to be not second-guessing your surgeon, but at least asking these questions whether your tumor might be suitable for partial nephrectomy. And so how much of an issue is this? I told you we're doing a lot of imaging these days. This, by the way, is just an example of a small renal mass sitting on top of the kidney, where it'd be very easy just to come around here and remove the mass and protect all of this healthy kidney. But I told you we're doing all this imaging, ultrasounds and CT scans. I mean, you can't get into an emergency room these days without having a CT scan. And a certain percentage of those patients with suspected appendicitis or whatever it might be will have a small renal mass. So 70% of renal tumors are diagnosed accidentally or incidentally. And they are small, so 4 centimeters would be an average size. Some of these can be benign, so it's particularly distressing if the kidney is removed for a small renal mass. It turns out to be benign. Sometimes it's unavoidable, but and we know that some of these, even if they're malignant, they don't grow very much, which we'll come back to later for active surveillance. So the partial nephrectomy is still a relatively invasive surgery. You're especially if you're doing it open, you're still sort of going through the flank, which can be painful and take a while to recover from. You're also cutting into the kidney. There's a relatively high risk compared to other surgeries of bleeding. There's a special risk with partial nephrectomy of urine leak. If you cut into the collecting system of the kidney, you can have urine leaking. So we're always looking for less invasive ways of taking care of things. And with kidney cancer, there are two new technologies. One of them is freezing, cryoablation, and then one of them is heating with radiofrequency ablation. This is an example of cryoablation where probes are put in directly through the skin under CT or ultrasound guidance into a tumor in the kidney, and then hooked up to an energy source that freezes the tumor. And it can be one probe in a small tumor, 2 or 3 probes in bigger tumors. It can also be done laparoscopically, so we can go in with our cameras and dissect out the kidney if the tumor is in a difficult location, and then put the probe in, and this would be a laparoscopic ultrasound monitoring the effect. The nice thing about freezing is that you actually get an ice ball in the kidney that you can watch on ultrasound, so you know exactly how much tissue you've frozen. And the radiofrequency ablation looks like this. You have this fancy antenna-like device. Here you can see it's put in from the back through the muscle right next to this is the spine, right into a kidney tumor here, and then it heats and thaws and heats and thaws, or I guess thaws actually, it would be frozen, but it heats and then lets it cool off again. And it has to get above 50 degrees. This shows you an example. One of the challenges with both technologies is deciding if your treatment was successful or not, because the tumor doesn't just disappear. There's always something there. So you can see this is a tumor here in the middle of the right kidney that here has the device sticking in the middle of it. It's being heated. And then this is 1 year afterwards. You still have tissue there. So it's not always easy to be certain that you've treated completely, and that can be a dilemma in some patients. Both technologies are relatively new and haven't been used really in enough patients for us, enough patients with enough follow-up, long-term follow-up, to be completely comfortable in recommending them to patients who otherwise would be good surgical candidates. So these technologies, it varies from place to place. Some surgeons are quite enthusiastic about it, and everybody's a candidate. For us, in general, only if you are somehow unfit for surgery, or if you refuse surgery and insist on one of these technologies. So sometimes in older patients, if they're unfit for surgery and also unfit for surveillance is the other option. Basically, some patients there is a slightly higher risk of recurrence, so the tumor will come back despite the treatment, and some patients will take that risk to avoid the invasiveness of surgery. Now, surveillance, funnily enough, is the newest technology. It's funny sometimes how things go in that direction, develop all these new techniques, and then come to the conclusion that really we don't need to be treating all of these. And there is some rationale for this. So as I've mentioned a few times, there are lots of small renal masses being detected. They're often in older patients who, as we would say, have competing causes for death. So, bad heart disease and other things that are more likely to lead to a patient's death than any small renal mass. So treating patients like that is not necessarily a beneficial thing. On autopsy, we're finding less renal masses. That means we're getting them before the patient dies of another cause, which of course is not beneficial. And although we're pulling out all these small renal masses, survival from kidney cancer has not necessarily improved. So the significant kidney cancers that are leading to death are still happening, even though we're getting rid of these small tumors. So these small tumors never necessarily turn into the big ones. So we know that the growth rate is variable, and that most are not destined to spread and may not even grow at all. And there's one large series from Cleveland. It's actually a large series from Toronto as well, I should put in here instead of Cleveland, but they had 110 patients, all older than 75 years, and we do tend to do this only in older patients because we just don't have enough certainty in younger patients. To tell a 60-year-old, well, let's just watch this, we're not confident enough to be sure that it's not going to turn into something later. So each patient had a solid enhancing mass on CT scan. That's kind of the definition of what we think a kidney cancer is, although 20 to 30% of them could be benign. And most of them were incidental, median tumor size 2.5 centimeters. They were followed for 2 years. And you can see that they grew on average of 1/4 centimeter in diameter a year. Almost half of them didn't grow at all. Those that did grow only grew 0.5 centimeter a year. And only 4 patients required some kind of intervention in the 2 years. Nobody died of kidney cancer. 1/3 almost died of other causes. So they were spared unnecessary treatment, which I think is a good thing. So the question, of course, are how do we follow? How often? Do we do ultrasound? Do we do CT? Do we biopsy? Do we not biopsy? How big is suitable for following? How old? How young? And when do we decide when to intervene? Right now, the only parameter we have really to decide on doing surgery or cryoablation or anything is size. So if it grows, we think that's bad, and we treat it. Another relatively new idea that you would think should have been done a long time ago is biopsying small renal masses, and this is something that Mike Jewett in Toronto is really pushing. In the past, we haven't biopsied. So most cancers you biopsy, right? If you have a breast mass, you biopsy it. If your prostate's suspicious, you biopsy it. In kidney cancer, we see something on a CT scan, we just take it out. And the problem has been that we haven't trusted a biopsy that doesn't show cancer. So then we think the radiologist missed it, and we take it out anyway. But the quality of biopsies is getting so much better that we are starting to biopsy a lot more, and then we make an informed decision based on what exactly the biopsy shows. So I want to switch gears now to treating advanced kidney cancer, so metastatic kidney cancer especially, and some of the medical options that we have. And I stole slides here from Christian Kolmansberger, who's our medical oncologist with a special expertise in kidney cancer, who I assume was invited tonight but couldn't make it. He's away, yes. So in the past, on my timeline at the beginning there, I'm sure you picked it up, we used to give immunotherapy for kidney cancer. So things we call cytokines, interferon, interleukin. They're natural compounds that the immune system uses to combat infections. And the idea was, we knew that kidney cancer was something that responded to immune modulation, and we just wanted to sort of kickstart the immune system to help it out. But really, these treatments worked only very rarely. A small percentage of patients actually had a benefit. A large percentage of patients had lots of side effects, so they're quite toxic. And ultimately, trials have shown that it was barely worthwhile giving any of this treatment. But luckily, we don't have to do that anymore. And now we have the new targeted therapies, which have come along in the last 10 years or so. And targeted therapy means really that it is a form of chemotherapy. When you think of traditional chemotherapy, they're basically drugs that are a type of poison that happens to kill cancer cells faster or more readily than normal cells. Whereas the targeted therapies are, they target specific molecular changes in the cancer that sometimes have been figured out before you target them, but also sometimes the drug works and then you figure out, okay, well I guess that pathway is important. But in kidney cancer, it's a very interesting history that the guys at the National Cancer Institute in Washington, D.C., or in Bethesda, Maryland, were looking at families with kidney cancer, especially with von Hippel-Lindau syndrome. And von Hippel-Lindau is, almost everybody in the family gets kidney tumors, and so they collected specimens and they were able to figure out the single gene that caused these kidney tumors and caused the syndrome. And very luckily, I would say, because it's not usually the case for this type of story, that same mutation is found in most kidney cancers in people without the syndrome. So with the syndrome, you have that mutation in every cell of your body. In regular kidney cancer, in clear cell kidney cancer, you have that mutation just in the tumors. So, but by doing this, they basically figured out the major genetic change in kidney cancer and were able to produce designer drugs to target that. And that is why now in 2012, we have a whole menu of targeted therapies. So they're mostly, you can put them in two groups, VEGF pathway inhibitors and mTOR inhibitors. What they all do, VEGF is just one target, mTOR is another target, but they all target the blood vessels ultimately, and kidney cancer is a very vascular tumor that is dependent on its blood supply. This is one of the success stories where it actually worked in the lab and then worked in the patients, which is not always the case. So you can see here how a small tumor can grow without much of a blood supply, but as it gets bigger, it needs its nutrients and its oxygen, and so it sends out signals to the blood vessels for new blood vessels to form and grow into the tumor, and then it itself can grow bigger, and it's sort of a vicious cycle. And so the new drugs actually attack the blood vessels. They don't attack the tumors themselves, they attack the blood vessels. So, and this is a list of some of the drugs, or all the drugs that are now available or close to being available. This one here, axitinib, is not yet on the list, I don't think, anywhere in Canada. No? You guys might know, but sorry? Not yet. Not yet, but it's certainly, the trials look good, so it will be soon. Bevacizumab is a special drug that is quite expensive, and it's not marketed in Canada. And I don't necessarily think we're missing out too much with that for kidney cancer. It's important in other cancers. And then the other two drugs down below here. So I'm just going to give you one example. I'm not going to go through every one of these drugs, but Sutent or sunitinib is the usual first-line drug right now in British Columbia and in most places. And it's a pill that you take once a day. I think it's once a day. I don't actually use it. Christian uses it, but I think it's once a day. You take it for 4 weeks on and then 2 weeks off, and you just repeat that cycle indefinitely. It doesn't stop as long as it keeps working. And so in this trial, you can see that they compared sunitinib with interferon, which is one of those cytokine therapies I told you about that doesn't work very well. And these are in patients who had nothing before, no other drugs before, just new diagnosis of metastatic kidney cancer. And now I don't think that you guys probably look at a lot of these survival curves very often, but you can see there's quite a difference in the sunitinib. You know, this is the percentage surviving, and this is the time, and so a lot more patients are surviving longer on sunitinib. So it was a very successful drug. It was the first of the series of very successful drugs. And this one I'm just going to show because this was sort of the next step, was an example of a next step, was with Afinitor, which is everolimus. And it was given to patients who had had a prior drug, so they'd already had either Sutent or one of the other ones, Nexivar, which is sorafenib. And then when that failed, they were given the second drug. And you can see that compared to placebo, a lot more had a response, certainly side effects, and their survival was, their survival without progression was better, so the cancer didn't get worse for longer. It's always hard to show an overall survival benefit, so that means patients actually live longer on drug, because as soon as a patient in the placebo fails, they then get the drug. So they will likely in the end do just as well, or almost as well. And this sort of shows you the type of menu that we have and how we use these drugs. So we're always looking at patients and their treatment as first line or second line. First line means they haven't had anything before. The second line means they've already had some treatment, and now we have to switch treatments. And we categorize patients by their risk, the risk of the disease, how quickly we think it's going to progress, and how likely we think it is to respond to treatment. And so I told you that sunitinib is the usual first choice. This is for good and intermediate risk. And pazopanib is relatively new and will probably replace some of this, but that remains to be seen. And then these are IL-2 is an older drug, and bevacizumab we don't have in Canada for kidney cancer. In the higher risk patients, just because the trial was done with temsirolimus, we can say that it works particularly well in high risk patients, but ultimately most patients in BC will get the sunitinib first and then move on to something if it doesn't work. For second line, it depends what you've had before. And so if you had a cytokine before, which now is not very many patients, it was when these drugs came out, then you can have one of these drugs. If you've had a prior one of these guys before, so sunitinib or pazopanib, then you can have one of these guys. Now, if you've had temsirolimus before, we don't know what to do. And that's one of the reasons why we give sunitinib first. So you can see it depends where the patient is in his course of the disease, what he's had, and that determines what he gets the next time around. These drugs are nice because they're targeted and they're not nearly as toxic as traditional chemotherapy, but they don't come without side effects. And I think it's very easy for us, particularly as surgeons who don't actually give these drugs, to play down the side effects, but they are significant. And as patients, you want to know about these beforehand so you're prepared to deal with them. And it's also important to know there are methods to deal with most of these side effects, things like rashes and high blood pressure, diarrhea, fatigue. Those are things that will affect your daily quality of life. There's some evidence that the drugs actually work better if patients have some side effects. This is particularly for, can I go back? For this one here, axitinib, the one that I told you is not yet available, but probably will be fairly soon. There's good evidence that if you have high blood pressure on the drug, that you're going to do better, to the point that you start at a usual dose. If you don't get high blood pressure, we increase the dose in 2 steps, either until you do get high blood pressure or until you reach the maximal dose. So that's a funny little twist with these drugs, where side effect is actually a good thing. We, of course, treat the blood pressure as well. And as I mentioned here, that there's, side effects are important, and dealing with side effects is important, and there is infrastructure for this at the cancer agency, so that patients are assisted in this regard. Now, I want to come back to surgery, of course, because I'm a surgeon, but these drugs have been developed in metastatic disease, and that is typically where new drugs are developed, because those patients often don't have a lot of options. And once they've been proven effective there, we bring them earlier into the patient's treatment course. And actually, I'm getting ahead of myself. That's the next slide. And this slide is a question of timing. So there are a couple of trials that showed that the kidney should come out before immunotherapy. And that's why we always take the kidney out before starting targeted therapy. But we're sort of extrapolating from immunotherapy to targeted therapy and saying if it was good then, it's probably good now. And that hasn't necessarily been shown. This trial at the bottom here, Carmina trial, is a trial that's been done in France to answer that question, where you either just get the drug or you get your kidney out followed by the drug. And that will help settle that debate whether patients actually need the kidney out, which right now is the standard. There's another trial called the Certime trial, which we are involved with here at Vancouver General. And it is not quite as extreme as this, but some patients get the drug first, followed by surgery, and others get surgery first, followed by the drug. So we're working a little bit on the timing of these drugs. And then this is what I was saying, if it works in metastatic disease, it might also work earlier on in the disease course. And some patients we do give the drugs to prior to surgery, but again, usually metastatic. Adjuvant therapy means that you've done surgery, you've removed everything. As far as you know, these patients have no sign of tumor left. And then you give them an additional treatment, knowing that they're at high risk for recurrence, and you want to decrease that risk of recurrence. And so there's one trial that has been finished, this ASSURE trial, and we're waiting for the results, which I think will be another couple of years. And then there's a trial with pazopanib, which is a newer drug, which is currently ongoing, and we're also doing. The problem with these trials is patients feel great. They're optimistic. They think they're cured, and some of them are, and they don't want to take drugs that cause side effects, which is perfectly reasonable. I don't know if I would either, but that makes it hard to do these trials. But we're trying to introduce these drugs earlier on into the course of treatment. So just in summary, some of the current treatment options we have for kidney cancer, radical nephrectomy is a gold standard, but more often than not is overkill and unnecessary. It is necessary for advanced disease, and if possible, we do it laparoscopically. Partial nephrectomy is the standard for anything less than 4 centimeters and is becoming the standard for anything less than 7 centimeters if it's technically possible. And it's better to do an open partial nephrectomy than a laparoscopic radical nephrectomy. There's an interesting dilemma that surgeons face. Now everybody's comfortable doing laparoscopy, and it's easier on the patient to do a laparoscopic nephrectomy than to do an open partial, because with the open you get the big incision, but really in the long term it's better for the patient to have the partial. So, and then the freezing and the heating are investigational as first line, but they've become part of the routine for older, sicker patients. And then active surveillance is something that we should be doing more often on older patients or those with a lot of medical problems. And then for targeted therapy, I think there's to a certain degree an embarrassment of riches. We have so many drugs now, we don't know how to use them, or we don't know how best to use them, which one comes first and which one follows. And the latest sort of push in the lab from a research point of view is to figure out what causes tumors to become resistant to these drugs, and then develop new drugs that target those mechanisms of resistance. And that is it. Thank you.